Hello, my name is Yejun Hong. I am a medical student in the University of Calgary, and our team is here to explain sickle cell disease as a link between ophthalmology and hematology. Abnormalities within the blood and the vasculature itself can also cause disorders within the eye. New vessel growths can occur in the iris, retina, and the optic disc, and can be fatal to vision. Increased permeability in vasculature or increased viscosity in the blood contents can lead to pathologies in the retina because they're very intricate microvasculature that goes on to feed the different layers of the retina. Sickle cell disease is caused by sickling hemoglobinopathy. This is an abnormality in the hemoglobin that causes RBCs to become very abnormal in shape, resembling a sickle. As you can see in the picture below, there are cells that are shaped like a banana. This change in conformation can be triggered by hypoxia and acidosis. There's a vicious cycle where the abnormal RBCs obstruct the microvasculature, and this causes tissue ischemia and in turn causes more sickling due to creation of hypoxic environments. Let's review a very simple anatomy of the eye. The retina is the innermost layer of the eye, while the middle layer is the choroid and the outer layer is the sclera. Anterior chamber is the space surrounded by the cornea anteriorly and pupils and the iris posteriorly. Sickle cell disease can affect these areas the most. Let's go over the more specific pathophysiology of sickle cell disease. The oxygenation induces conformational change in the hemoglobin S, which stands for sickle. Hemoglobin S has the beta-6 location changes from glutamate to valine, which is a significant change considering that glutamate assumes a negative charge and valine is neutral electrically. In this conformation, different interactions between amino acids causes hemoglobin S to assemble into polymers in instances of hypoxia. This results in overall a sickle-like shape in the red blood cells. The cells become more sticky with this conformation, and it results in cellular adhesion with other cells and endothelial factors. The vascular factors, as well as the adhesion together, leads to vascular occlusion, as shown in the diagram on the right. African Americans are especially vulnerable to sickle cell disease, and in terms of geography, West Africa in particular. Having a family history of the sickle cell trait may cause that individual to inherit the sickle cell disease alleles. Sickle cell disease is a systemic disorder, and a whole constellation of symptoms can present. For example, sickle cell disease can present with anemia, dark urine, sclera icterus, which is yellowing of the sclera, edema of the hands and feet, sickle cell retinopathy, as well as traumatic hyphema. Hyphema is a collection of the blood in the anterior chamber. Complications that can arise from sickle cell disease includes the vaso-occlusive crisis. This occurs when there is significant occlusion from sickling of the red blood cells, and it is a painful sensation in the extremities, back, chest, and abdomen in particular. Acute chest syndrome is the most common cause of death from sickle cell disease. This is pulmonary infiltrates, according to radiography, plus one of the three, fever, chest pain, and lung presentations like tachypnea, wheeze, and cough. Hemolysis, or breakdown of red blood cells, cholelithiasis, or gallstones, and pulmonary hypertension are also presentations and complications that you should not ignore. Chronic organ damage from this disease includes the spleen and in the extremities, forming leg ulcers and even DVTs, which is deep vein thrombosis, renal disease, osteonecrosis, and erectile dysfunction or infertility. Blood may be found in urine, and urine's osmolarity may be elevated. Stroke can occur from sickle cell disease as the sickling occurs within the vasculature of the brain as well. And sickle cell retinopathy, which we'll cover in this subsequent slides, can also happen as a complication. In sickle cell retinopathy, one of the end organ complications of sickle cell disease, there are 5 stages that we should be concerned about. Stage 1 is when there's no proliferation, and it can present in the retina as venous tortuosity, salmon patch hemorrhages, and iridescent spots. Cottonwool spots from infarction, and hairpin vascular loops and macular infarction can also occur. Angioid streaks, sunburst, scars, as you can see in dark patches in the right top photo there, can occur. And comma-shaped conjunctival or optic nerve head vessels, as well as peripheral arterial occlusions can also occur. In stage 2, AV anastomosis, peripheral silver wire vessels, and shunt vessels can be formed and observed. Stage 3 is the proliferative and neovascular stage. You'll see a C fan-shaped peripheral neovascularization. And in stage 4, there is vitreous hemorrhage, from the contraction bands contracting around the C fans. Lastly, in stage 5, retinal detachment can occur, either tractional or rhegmatogenous. This can form from contraction of the vitreous traction bands from stage 4. Beta thalassemia, hemolytic anemia, or pulmonary embolism within the lungs can be alternative diagnoses. For sickle cell retinopathy itself, and with slight or non-apparent symptoms of other sickle cell disease symptoms, the differential diagnosis can be diabetic retinopathy, Eales disease, simple vascular occlusion within the retina, ocular ischemic syndrome, and hyperviscosity syndromes, like polycythemia vera and Waldenstrom's macroglobulinemia. When seeing the patient, in history it is important to ask the family history of anemia or sickle cell disease. With slit lamp exam, examine closely each component of the eyes. In the fundus exam, pay attention to vascular abnormalities, any scars or hemorrhages, and look for the sunburst and C-fan patterns, and check for retinal detachment. For investigations of sickle cell disease, newborn screening for sickle cell would be an effective way to identify individuals with the disease and to initiate early treatment. This is done by taking a heel prick sample and running an HPLC with it. Hemoglobin electrophoresis can be another investigation from the blood sample, and fluorescein angiogram of the retina to observe any capillary non-perfusion at the hairpin loops is another test to evaluate the severity of sickle cell complications. Let's go through the treatment for sickle cell disease. First, avoiding hypoxia or the cold will be significant to prevent episodes of sickle cell symptoms and complications. Folic acids help make new red blood cells and may help with the oxygen supply of tissues around the body. Hydroxyurea increases the hemoglobin F levels, which interrupts hemoglobin S polymerization in the oxygenized state. It also increases MCV, which is an average size of the red blood cell, and cell hydration as well. Infection control with regular immunization and prophylactic penicillin is another treatment option. Disease-modifying therapy includes chronic transfusion program with iron to flush out and replace the sickle cells with healthy RBCs. Transfusion would be every 3 to 5 weeks with a goal of hemoglobin S being less than 30% of the entire hemoglobin composition. The curative therapy would be to replace the source of hemoglobin S production in the first place, the bone marrow transplant. For fatal complications like vaso-occlusive crisis, pain control and hydration would be unimportant steps to take. And for acute chest syndrome, of course, pain control and hydration. We'll also look into oxygen, pulmonary toilet, infection treatment, and transfusion as well. For sickle cell retinopathy, in cases of active peripheral neovascularization, using scatter laser photocoagulation with 500 micrometer spots to non-perfused retina can be an effective treatment. An intravitreal anti-VEGF can act against neovascularization and provide temporary relief. In cases of tractional retinal detachment or vitreous hemorrhage, retinal surgery is indicated by retinal specialists. Nowadays, with proper care and adequate treatment of sickle cell disease, patients have 95 to 99% survival rate to adulthood. So here's the linking slide again to remind you of the connections between ophthalmology and hematology and how this is strengthened by sickle cell disease presentations. Here is a thorough and helpful flowchart as a summary of everything we've talked about in this presentation. And this is page 1 of the references, all the sources of information we've gathered to put together this presentation. This is page 2. Thank you for watching this video.